So I am known for being the biggest procrastinator on the planet, and I just turned my slides in like 30 minutes ago, so they don't have them loaded. But a lot of my talk is going to be me kind of storytelling, and then also there's room for some discussion at the end and what y'all's experience has been with medical billing nightmares that I'm sure you've had of your own, and also working with patients. But the first part, I was just going to talk about, what are some of the consequences of aggressive billing and collection practices. And I actually got a firsthand look at this. First of all, let me introduce myself. My name is Geraldine Arneson, and I am a pharmacist by trade. I've been a pharmacist for 25 years. Started out in oncology in the Air Force, and spent about 14, 15 years either as active duty or as a civilian for one branch or the other until 2014, when I switched over to civilian medicine and went into managing multiple infusion center pharmacies. And that was for the Bon Secours health system in Virginia. And then in 2019, I switched, and I had built multiple patient assistance programs for Bon Secours, and I wanted to continue to do that for other hospitals and health systems. So I went to an independent community hospital in Virginia, and by doing that, I actually turned into what's called a revenue integrity pharmacist, where I was looking all day. I was just reviewing infusion center claims to look at how we were reimbursed, and looking at the cost versus the reimbursement side and whether we were getting paid appropriately, looking at payer contracts and all of that good stuff. So they actually sat me inside the billing office, which I thought was interesting. And by doing that, I got a real firsthand look, not just because I sat in the billing office, but because I was setting up this patient assistance program from the ground up. So I was filling out the applications for the free drug and the copay assistance, and I was collecting those income documents from the patients. And through doing that, I became actually very close with the patients, hearing stories from them and these stories were different than what I had heard from Bon Secours, but they would bring me documents like a warrant in debt, and the plaintiff was the hospital, and they didn't know what to do. And that was kind of my first, like, that's bizarre. I've never seen this. So patients were actually scared to be treated at this hospital. And so with that patient who had the warrant in debt, I told her, I'm not really sure what the whole warrant in debt is, but we've got to get you set up on a payment plan with the hospital, even if it's just $25 a month. But her concern was she would not go to the billing office because she actually thought she was going to be arrested, put in handcuffs, taken away. And I said, Mary, let's go over there together. I'm fairly sure that's not going to happen, but I'll go with you just to make sure. And so I escorted her over to the billing office, and we sat down around a table. It was very intimidating just to set up $25 a month payments with the hospital. So that was my first experience. And then I knew from Bon Secours that every hospital has a financial assistance or hospital charity program. And so just being my usual annoying, curious self, I just kind of roamed around the hospital and was asking different people, like, do you have a copy of the application for our financial assistance policy? And no one could answer me. Somebody at the front desk gave me a Medicaid application, and I was like, okay, thanks. There was no advertisement for it, and in comparison, whenever I went to the Centera healthcare system in this area, I knew every time I went in for an x-ray, for labs, whatever, I was given a brochure on the financial assistance policy. So I looked it up and saw, like, yeah, that's the regulation, is you have to make patients aware that there's financial assistance policy whenever possible. So again, roaming around the hospital, I don't see any posters. I don't see any pamphlets. So I annoyingly approached the patient access leadership about this, because they're the ones who's in charge of the financial assistance policy, and they're telling me there's a poster in the works. And so I said, oh, okay. So then I met the financial counselors, and they were really, really great. And they actually gave me the inside scoop about how all of this came from the director of the billing office, where she had learned of a program in the state of Virginia called, it was just called the Debt Set-Off Program. And so I looked it up, and what it does is it allows you to garnish state tax returns if the patients don't pay their bills. So then I started putting two and two together, and I said, okay, so if you offer patients financial assistance, you incur debt on behalf of the hospital. It's good debt. It's debt that they can write off. However, if you do that in comparison, if you don't do that in comparison, if I don't tell patients about what their financial options are, and I let these accounts go to collections, and I let them go to court, and it rules in the hospital's favor, now I can start garnishing whatever I want. And then that garnishment, the money from that garnishment, is direct revenue for the hospital. It's cash. It's straight cash for the hospital. So then that increases their operating margin that they work off of. So I'm not sure what possessed me to do this, or to think that I could do this, but I made an appointment with the CFO, the hospital, because I was so disturbed by it. As you know, I'm a pharmacist, and yes, I got into patient assistance, but you know, at heart, I feel like I'm a patient advocate, and I just was so horrified by this. Advocate Summit, and also math. So I made an appointment with the CFO, because at the same time, I was acquiring a stack of patient folders who I had applied for patient assistance for, who I knew clearly were eligible for a financial assistance program, where they were $75,000 in debt, $100,000 in debt. And I was thinking, this is absurd. That no one would offer these patients an application or anything. So I made an appointment with the CFO, and I lined up several cases, and my very first case was a patient that I talked about yesterday in the Medicare course, who was 68, who had Crohn's disease, who was receiving a Remicade infusion every 8 weeks. and she had a really crappy Medicare Advantage program policy. Hey, Matt. And she was literally incurring $1,200 every 6 weeks, no, every 4 weeks. She was incurring a $1,200 co-insurance for every treatment that she was receiving. So, and then her income, she literally was making $9,800 a year. And that was strictly, she was living off of her Social Security Administration benefits. And she only was making that much because her Crohn's disease was so severe that she could never hold a full-time job long enough because she had to go to the bathroom so many times a day that she couldn't stay at work long enough. So because you pay into Social Security, obviously her Social Security benefits were never going to be high enough that she could live off of. And I actually became very good friends with her. But the very first thing I did, although we had a Medicaid vendor in the hospital, the very first thing I did, and I had never done this before, was I enrolled her into Medicaid on my own. I just was like, somebody has to do something about this. But without doing that, she had already incurred $80,000 worth of debt. And I thought, you know, she was basically, when I talked to her, you know, I asked her what her plans were, or what was, you know, I just wanted to know the story. And she said, you know, I continue to get bills, but I'm so overwhelmed. I just put them in a drawer and I just close the drawer, and I don't even want to look at it. I don't even want to deal with it. So I said, okay, her name was Connie. And I said, Connie, all right, just do me a favor, take the bills, put them in a bag, bring them in. Let's just deal with it. Let's just look at it. So she brought them in, and sure enough, you know, it was years worth of bills. And I thought, never at any time, because this lady has to check in at the infusion center every 4 weeks. They see her balance. Never at any time did they ever offer her an application for the financial assistance program. Like, you know, that is a culture that is created among the hospital staff. And so she was the first case that I brought up to the CFO. And, you know, they couldn't argue with me because I also pulled the financial assistance policy, which showed that patients were approved retroactively going back 8 months, and they could also be approved going forward 8 months. But he knew that the case was so severe, he didn't have any choice but to write off all of her debt. So I continued to find cases like this over and over again. And eventually they just got so sick of me that they decided to revamp the whole financial assistance policy. And so let me see if I can find in my slides where I'm at. I think we're a little past this. So just to back up, so I can kind of tell you once I started digging in, I'm sure everybody has heard of, well, maybe Epic is one of a few major electronic health records out there. And health systems really like it for its flexibility and being able to modify it and tailor it, custom tailor it to your facility, especially on the hospital billing side. But the way that they had set it up was that after a patient, so it's not like the pharmacy side where the claim is sent and paid immediately, just, the patient gets treated and then that claim will get routed around to all of these different people and they do their checks and balances on the claim to make sure all the charges are added. But then after that, then the claim gets submitted to the payer if they're insured. But once that happens, once the claim is set out, what they do is they do a soft hit on the patient's credit. And they do that to kind of determine, try to predict the patient's ability to pay that bill. And so if their credit score is low, they will actually outsource them to collections immediately. So they don't even give them one 30-day statement, just immediately to collections. And they would have, and this is very common to have more than one collection agency at a hospital. And so this hospital had 2 collection agencies, and the way they determined which one it would go to was determined by, it was an alpha split, so based on their last name. And so if their credit was okay or not so bad, then they would get that first 30-day statement, and then they would have 3 months basically, or 3 billing cycles for them to make a payment before they outsource to collections. Then once it went to collections, that's when now the collection agency has the ability to sue the patient in court. And it's kind of like, that's where the hospital can wash its hands of being on that, being affiliated with that lawsuit. So, you have to really look at that warrant in debt to see that the hospital is the plaintiff, because it didn't outright say the name of the hospital. It was kind of like a doing business as type of thing. So you had to really dig. But, the patient thought it was the collection agency suing them, definitely. And then what was even more disturbing was that there were so many lawsuits that the community courthouse was reserved every Tuesday and Thursday. Is it Tuesday and Thursday? Tuesday and Thursday. Every Tuesday, Thursday morning was dedicated just to suing the patients in this community. And this was, it was not a large urban area, nor was it a large rural area. It was a medium size community. But, it touted itself as being there for the community, as being an independent community hospital. It wanted to stay independent. It wanted to stay as being the resource for the community. So that was really ironic. And the other thing that I learned by working over there was just how easy it was to pull that account back from collections at any time. So, I'm sure everybody has heard like the number of mistakes that happen the statistics are 90% of hospital bills have some sort of error on it. So if you had someone who was savvy enough to pick up that error and they called and complained about it, they could easily, it was literally just like clicks on the keyboard, and they can pull that account right out of collections. So I think for me, being a pharmacist for 25 years and being clinical, I think what was difficult for me was understanding how the billing side, they did not refer to the patients by the patient name. They were just account numbers. So they were an MRN, a medical record number, was their medical record number, and then each visit was an account number. So when we communicated with each other back and forth via email or whatever, we didn't talk about the patient as a person. We talked about this account number or that account number. We actually didn't even refer to their medical record number. They were just reduced down to an account number. So, and I think it was a good experience for me, but also it was good for the pharmacy because I became an intermediary between myself and the pharmacy, and I started to understand the revenue cycle language because it's a totally different language than the clinical language. And so, whenever the pharmacy would want to look at something like the infusion center denials, we would ask the revenue cycle team, and their first response would always be, "Why do you want to know? Why do you want to look at that?" And we were like, we just want to see if we're getting paid for the $30,000 drugs that we're purchasing. That's all. We're not looking to see what you guys are doing. We just want to know. So for me to eventually be able to pick up that revenue cycle language was very valuable. But anyway. So I actually then, just one thing to know about me is I have always been like that weirdo kid at the back of the class that is like raising my hand, like, why? So, of course, so I get a phone number on the warrant in debt, and I call the phone number, and because I want to talk to somebody at the collection agency and find out what's going on. I just want to ask questions, And so this lady working at the collection agency was super nice and actually became friends with her. She kind of gave me the inside scoop, and she said the majority of the patients don't show up to the courthouse because they're obviously terrified that they're going to be taken away. So when they don't show up, really? Already? Seriously? Gosh. Okay, so when they don't show up, the ruling is automatically in favor of the hospital. And so that's what then gives the hospital permission to garnish anything and everything. And that's what then allows them to do the garnishment of the tax returns. So my advice to patients always is to show up to the courthouse, because when they do that and they go in front of the judge, all they have to do is say, I can't afford to pay this. And then that settlement will be in favor of the patient, and they have to accept whatever kind of payment plan the patient can give, even if it's just $5 a month. So I know it's intimidating, but my advice is to show up. So then, as far as this tax set-off program, there's rules to it. So I went digging on the internet. You would think I'd have a lot of time doing all of this research, but I don't. But so I went looking at the rules, and you're supposed to review the account for medical billing errors. And so I asked somebody in the billing department, like, does this happen? And evidently they hired like 2 temp workers from a temp agency and who received no training of what they were reviewing, and just to check that box that they were reviewing these claims. And so then the file gets uploaded. They do this like on a quarterly basis. They upload it to the state. It was the Virginia Department of Taxation, and matched by Social Security number. And so a notice is supposed to go to the patient saying, hey, we're going to garnish your tax returns. But the notice didn't get to the patient until after the taxes were already garnished. So the patient then would be expecting to have a tax return coming, you know, in the amount of $1,200. They were going to use that money to pay off, you know, some debt or whatever. And then all of a sudden, you know, the tax return isn't coming. They're wondering what happens. So they call the state, and the state tells them, hey, your tax return was garnished by, that's when they find out it's the hospital. And then now the relationship between the patient and the hospital is completely severed at that point. And patients are angry, and to the point where they had to put bulletproof glass in the billing office. And I thought, if this like does not give this hospital a clue that what they're doing is not appropriate or good for the community, that I don't know what other indicator could be done here. So then on top of it, so let's say the patient's debt was $2,500, but their tax return is only worth $1,200. They could still garnish them year after year until that debt was settled. So, and there was nothing that the patient could do about it. They were just kind of stuck in this cycle. We'll skip over the extraordinary collection actions, but I would say that I think having your taxes garnished would be considered an extraordinary collection action. But in that would be also being sued by the hospital. But other things, and you know, it really varies by state, but other states, they can garnish anything from wages to bank accounts. So you can literally take money out of someone's bank account to settle a hospital debt. So you're like literally taking food out of someone's mouth. And I think what's really disturbing is that I think people think that this is being done by for-profit hospitals, but they're not. It's being done by nonprofit hospitals who, you know, you get a tax break in return for that nonprofit status. And then on top of it, I don't want to go too far down this road, but layer on top of it the 340B entities who are getting a further discount on their drugs, who are also participating in these activities, makes it even worse. So this is just talking about how the hospital then they did an overhaul of the financial assistance policy. And I think they were really proud of themselves because it took it from the eligibility they could, prior to this overhaul, to qualify, you had to be at 200% of the federal poverty limit. And if you think about the way I think about the federal poverty limit is 100% of the federal poverty limit is about 1,000 for one person is about $1,000 to $1,200 a month. So 200% of the federal poverty limit is about $2,000 to $2,400 a month. So that would be the eligibility requirement. So they actually took it up to 400%, and then above 400% is where they then began discounts. But then they also finally added in, and I think they had to because they had to look at how much debt that the number of patients they had in debt, but they had to take into consideration not just the federal poverty limit of the patients, but also there's a word for it. It's in one of my slides here. The medically indigent. So if the patient owed greater than 25% of their yearly income, then they would also be eligible for discounts. And I can honestly say that working at Bon Secours is a Catholic charity hospital. And in contrast, at 6 months, they truly wrote off their debt, at least the Bon Secours prior to I would call it a merger with Mercy, but I think it was more of a hostile takeover. So, but it used to be that they really did write off the debt at 6 months. So I wasn't used to seeing patient balances of this size that I saw at this hospital. Then the other interesting thing was, I think this made me more angry than anything, was that there was an ability to use a tool to determine presumptive charity. So they could do it couldn't be for future accounts or past accounts, but account by account, they could actually determine through a soft credit check whether the patient would be eligible for charity, and they could go ahead and apply the discount electronically through the EHR at the time of service. So then my question became, like, why aren't we doing this for everyone? Because I was seeing it like applied here and there, but not consistently. And they had a variety of excuses as to why they did that, but just to know that that's an option for almost every hospital to do the presumptive charity route. And this is just going over that exceptions can be made to the financial assistance policy. And so my stack of exceptions became like this, to where my meetings with the CFO turned into weekly meetings with the CFO, where I just became so annoying that I think they were worried I was going to go public with it, that they just started to write off accounts. And I was okay with letting them think I was a little unstable. So, I got to know these patients, and a lot of them had, not just cancer, but they had rheumatoid arthritis or Crohn's or ulcerative colitis, and they ended up being, longtime patients of the hospital for 6-8 years or something. And I thought, if we don't do something about this, we're going to lose a ton of patients. So, and it just wasn't fair. Principally, it wasn't fair. I'll skip. But it was funny to watch the hospital scramble with the No Surprise Billing Act because you couldn't bill for out-of-network providers anymore. And they were notorious for doing that. And so I think these slides will be available, but I put in here a website where if you have questions about, or if you want to direct a patient to do like their own dispute or dispute resolution, there is a CMS website that takes them step by step, which I thought was really interesting and cool. And then if they go through it and they still don't understand, then it directs them to two different numbers. One is it's the No Surprises help desk, and then to find a patient advocate near them.